From the RSNA, I'm Dr. Jana Ivanice, and this is Radiology, Imaging Cancer. We are back in your feed with a special podcast episode. Today's interview was conducted by another wonderful trainee editorial board member, Dr. Francesca Rigiroli. Francesca is a clinical fellow in the Department of Radiology at the Beth Israel Deaconess Medical Center in Boston. She interviewed Dr. Marwan Moussa, interventional radiologist also at BIDMC. So as you can see, we are continuing with the theme of outstanding interventional radiology research, following our recently published episode where Dr. Vishnu Chandra interviewed Dr. Julius Shapiro, also an interventional radiologist and researcher at Yale. If you have not yet listened to that one, I hope you do. Back to today's episode. Drs. Rigiroli and Moussa will speak about Dr. Moussa's recently awarded RSNA Foundation Research Scholar Grant, which he received for his proposal titled Combinatorial Thermal Ablation and Nanodrug Immunomodulation to Promote Anti-Tumor Immunity. Fascinating topic. Not only did Dr. Moussa discuss his very interesting research, he also shared fascinating insights from his unique experience as a physician-scientist in IR and the importance of mentorship. I hope you enjoy this podcast episode, and as always, we look forward to your feedback.
This is Francesca Rigiroli, Clinical Fellow at the Beth Israel Deaconess Medical Center in Boston, and member of the Trainee Editorial Board of Radiology Imaging Cancer. And today I will interview Dr. Marwan Moussa, Interventional Radiology at the Beth Israel Deaconess Medical Center. Dr. Moussa graduated from Alexandria University in Egypt and completed his residency in radiology at the University of Arkansas, followed by an interventional radiology fellowship here at BIDMC. He has been attending physician at BIDMC and instructor at Harvard University since 2019. Hello, Marwan. It's a pleasure to have you on our podcast.
The pleasure is all mine, Francesca. Thank you so much for having me and the opportunity.
You're welcome. It's nice to have you. Marwan, you were recently awarded with the RSNA Foundation Research Scholar Grant, and congratulations.
Thank you so much.
The title of your proposal is Combinational Thermal Ablation and Nanodrug Immunomodulation to Promote Anti-Tumor Immunity. I know that you have been involved in research on imaging-guided thermal ablation for at least 10 years. What is the most interesting aspect of this research that moved you to this field?
Yes, thank you. So again, it's a pleasure to be here. And so indeed, I've started research very early on. Right after I graduated from university, I spent 3 years here at the BI before going to Arkansas. And since then, I've been always involved in image-guided or thermal ablation research, particularly RF. It's a tough question. There's a lot of things that I find very interesting, whether it's the devices, how you deliver the thermal dose, but definitely what's really interesting now to me, and has been since actually 2013, has been the biological effect of the energy on the tumor. So once you apply that heat, what happens beyond the cooking, and particularly to the immune cells around that. And we're coming to understand more and more that with different forms of ablation and how you perform it, you are eliciting a host response against these neoantigens and basically developing some sort of immunity against the tumor. For most ablations, that is weak, but it is something that we will see what cases that are called abscopal effects, where you will ablate one cancer and another cancer at a very different location in the same patient will start to shrink and almost completely disappear. So we're trying to study, understand, and exploit this phenomenon.
Oh, that's really interesting. So in your opinion, in few words, what are the advantages and the limits of tumor ablation right now?
As it is, ablation is, the advantages is that it's minimally invasive, it's percutaneous. We call it pinhole surgery because the patient comes in and out and they go home with a Band-Aid. pretty much a couple of hours after we're done treating a cancer. So minimally invasive has very low morbidity and mortality rates when compared to other alternatives such as surgery. Again, like it's a single same day thing. They go home the same day and the next day they're out and about carrying on with their life. So we preserve life, we preserve quality of life. The third is cost. It's very low cost to set up, to maintain, in comparison to surgery. It also has a very low economic cost to, how many days after the procedure do you still need to stay home or recover or all of that, and you're almost the same. So that's the advantages. The disadvantages is that there's some size limitations to how much thermal ablation can treat, although you can compensate for that. But generally, beyond 3-5 centimeters, the local rate of recurrence becomes much higher with ablation. The other is we don't understand exactly the systemic effects of ablation. For the longest time, ablation was thought to be in situ control, or like basically you're cooking or freezing a particular tumor, and that's it. But lo and behold, we have found a whole array of systemic effects to that treatment. One of them, which is this anti-tumor immunity that develops, and we are not taking advantage of that. So I think these are the two main disadvantages or limitations of this technology.
Mm-hmm. And so, how are you gonna try to overcome some of this limitation with this grant?
We're trying to exploit this very weak anti-tumor immunity that comes with ablation. Particularly, we found out that if we use nano platforms, which are basically packaging agents in nano packages, very, very small particles, and injecting them right around the time when ablation is done, they end up localizing with very high concentrations in that hyperemic zone that you find, even after a CT of an ablation zone, that periablational rim. That's the most biologically active part of, right next to the ablation cavity. So, and that's where the anti-tumor immunity develops. So we're able to co-localize drugs to the area which is most biologically active, that is receiving all of these neoantigens and creating that anti-tumor immunity. That is what this grant is trying to tackle or trying to answer. Mm-hmm.
So basically you're going to try to use this immunotherapy to improve the effect. And so how is the immunotherapy delivered in this case?
So we use what's called a liposome. A liposome is a lipid layer molecule where we can package agents so that they're not taken up, by the liver or the spleen and delivered. Being in the liposome allows that very rapid delivery and trafficking into that periablational rim and decreasing toxicity to the host. And once it gets to that periablational rim, it targets a particular biological process. In our case, because it's an antigen-dependent process, we are injecting GM-CSF, the granulocyte macrophage colony-stimulating factor. It's basically an antigen-presenting immunostimulant, particularly for the dendritic cells and the macrophages, which pick up the antigens of the neoantigens of the tumor and break them down and then present them and prime the T cells. So we want to see if when we inject that it activates the dendritic cells which prime the T cells, and the T cells then go out on a search and destroy mission in the body to find other tumors.
So I assume, based on what you're telling me, that can may be also useful to control the disease systemically, like when it's spread outside of the liver.
Yes, so we're trying to experiment to see if in a model there where an animal has two tumors separate from each other, if you treat one and inject the liposome, what happens to the other one? Does it stop growing? Does it regress? Does it, grow but slower than the controls? How effective is it? And in other scenarios, such as trying to simulate a recurrence where basically you treat one and then you challenge the animal with a new tumor and see if it has enough resistance and memory against that tumor and basically aborts that implantation. So we're trying to simulate those two clinical scenarios, like a macrometastatic scenario where you have a patient who has more than one metastasis and you treat one and you see the effect of the other, or oligometastasis, one that has, a small metastasis somewhere and you treat that and then they're going to have a recurrence and you see if you add that on to the ablation, does that cause the recurrence to decrease? So
it's really interesting. So in your grant, you're planning to use to apply this treatment on models of breast and colon cancer with metastasis. Which one do you think would be more effective? Which cancer will benefit more?
So nobody knows the answer to that, and that's why it's interesting, is that theoretically this can work with almost any solid tumor that has a neoantigen. It's exactly how immune cells identify bacteria as non-self. So you have that potential. The improvement in outcomes or refining the paradigm will come when we figure out that, for instance, and I'm just using a hypothetical here, but that a colon cancer that is MSI high, which is basically an indicator of how much mutagens they have, is better ablated with IRE to release the neoantigens with an immunostimulant and like a GM-CSF and a checkpoint inhibitor, like PD-1 inhibitor, versus, let's say, something like a melanoma is much better with a STING agonist after cryoablation. So that's where the refinement will come. But I think we're using it in multiple cancers as a proof of concept that it probably will work with any solid tumor.
Interesting. So do you think that in the future this treatment may represent an alternative in case of tumor recurrence?
So I hope it actually is more like a mechanism of deterrent or prevention of recurrence, where it is the standard of care in any oligometastatic disease patient or even any patient with macrometastasis, is that you treat with an ablation modality, add a liposomal or nanopackaged immunostimulant, and then probably add on top of it a checkpoint inhibitor or something, and that allows the tumor to get exposed, the body to identify it, tear it down, and then build a memory, a robust T-cell memory that will protect the patient for lifelong immunity. It's pretty much, we're trying to recreate what we did with bacteria to some capacity, yes, and vaccination.
I see. But, it sounds like a lot. Do you think this treatment will be well tolerated by patients?
So that's a very good question. I think the true answer will come when these paradigms advance into clinical trials and stuff like that. But generally, it actually should make everything a little bit more tolerable. For instance, when we combine ablation with liposomal drugs, the amount, instead of, let's say, giving the drug once every other day, you basically give it once or twice. So you do less doses, and when we do pharmacokinetics, we find that the uptake in organs such as the spleen, liver, and other areas, it actually is much lower than when combined with ablation in liposomes, than when it is just liposome alone or free drug alone. So it should allow for patients to tolerate these paradigms much better and have less toxicity.
Very interesting. So to do your research, how important is it to collaborate with other physicians of other specialty to perform this kind of interesting?
It's imperative. It's like essential. I mean, once I took the decision to venture into immunotherapy, I went out seeking an immuno-oncologist, and my collaborator here is Dr. Vicky Villasuso, and I'm very fortunate to have her because you need that expertise to vet ideas, to design an experiment, to interpret the results. And that just doesn't go for seeking out physicians of other specialties, We collaborate very heavily with pharmaceutical colleagues, and so we collaborate with Northeastern Pharmaceutics Department, and they synthesize and package all these nano molecules for us. We collaborate when we were developing some of these probes with the engineers. So I think to bring in a novel idea, one needs to venture out and talk to, collaborate, and cross-pollinate with as many fields and disciplines as he or she can find. It definitely makes a huge difference, and really is the only way to bring something novel about.
Thank you. So you are definitely an expert on this topic and in research. What would you suggest to a young radiologist who wants to venture into research in interventional radiology?
Well, I appreciate you saying that I'm an expert. If you mean expert to someone who does a lot of mistakes to learn, that's me for sure. But that's very kind of you. I think definitely the one thing I've learned along the way as I ventured and invested more of my time and my heart into research was the value of mentorship. The one thing I always tell prospective investigators or researchers or people who are looking for research opportunities is like, who is your mentor? Or have you researched your mentor? Have you researched their prior, mentees and where they ended up and what did they do? And like my mentors, Munib Ahmed, Nahum Goldberg, have been instrumental in my professional and personal development throughout these now 13 years. A good mentor doesn't have the answers, but they ask you the right questions. And I'll give one example. I was eager to get into radiology, and I emailed Nahum about just wanting to apply and if he would support me. And I think I even said I would go into medicine, but I just need to get into a residency. And he took the time and he asked me, he said, Marwan, I thought you were committed to interventional oncology. He didn't even say medicine oncology or radiology or interventional radiology. In our original conversations and what I had talked about, he reminded me, I thought you were committed to interventional oncology. Mm-hmm. And he basically said, if you have a change of heart, I'll support you. I'll help you find something. But if you want interventional oncology, that's not the way to go about it. You need to do so and so. And I remember that we hung up, he emailed back, and I was like, no, you're correct. I am committed to interventional oncology. That's what I want to do. And sure enough, here I am.
That's fantastic.
So, yeah, mentors.
So the mentor should also give you those answers that sometimes you don't want to hear.
Yeah. Believe me, I get that very regularly from them.
Yes.
So, yes.
All right. Thank you so much for being with us. Keep up with good work.
Thank you so much, Francesca. It was a pleasure. Thank you so much.
This concludes today's episode. Many thanks to our guest host, Dr. Francesca Rigiroli, and to Dr. Marwan Moussa for this interesting interview. And congratulations again to Dr. Moussa on his RSNA Foundation Research Scholar Grant. Thank you all for listening, and we look forward to your feedback as always via email or on Twitter. I'm Dr. Jana Ivanice, and this is Radiology, Imaging Cancer.